So, good evening, all the aspirants present here. The session for today is Infectious and Immune Diseases. It's a class 2. All the aspirants are required, this is going to be an interactive session. So, any question, any doubts, you can just put in the chat box or even can unmute yourself. So, the speaker that we have here is Dr. Suvadeep Sen. He is a consultant, ICU, Apollo Hospital, Navi Mumbai. Thank you so
Thank you, Padma, for the introduction. Good evening, everybody, and happy Ganesh Chaturthi from India. So today is a kind of Ganpati Puja in India that is happening. So let me just share. Yeah. Can you see my slide, everybody? Hello. I request people, whoever is there, to unmute and please respond. Is that okay? Hello.
Yes, sir, the slides are visible.
Slides are visible. Thank you. So the sessions will be interacting as Fatma has said. I hope you have been there in the part one of this session, which happened probably a month back. If anybody was not there, uh, you can let me know. But actually, I've forgotten. Fatma, do you remember how many slides you have covered over there? Or anybody can volunteer and tell me that how many
No,
slides you have
last
covered?
time we did, I think, 10 to 12 questions.
10 to 12 questions. Okay. So we talked about so we talked about the sepsis-induced immune modulation and immune paresis a little bit. We had a couple of questions on that topic. This immune pathophysiology of sepsis, we talked about a little bit on that part. We talked about this compensatory anti-inflammatory response syndrome or CARS. So all these things are very, very favorite to the European examiners because that have been very well discussed in the intensive care society of European intensive care societies. We spoke about this complement mediated problems and the complement associated infections and the infections they are common in the complement deficiency. We talked about a lot about this immune checkpoint inhibitor associated infections and the problems. We talked about HLH. We talked about this graft versus host disease. I think we have all covered so far. We talked about this. These are all immune checkpoint inhibitor related questions. Sometimes they come. Sometimes, so these are the kind of ring enhancing lesion, the MRI, questions related to the CMV. We have covered that part. Questions related to the BK virus. Did you cover BK virus diseases? Anybody who were there at the time of in the first session, if he or she can
Yes, we
say,
did. Yes, we did.
we did this BK virus related. Thank you. So I think question number 12 we have covered. This is BK virus associated nephropathy that we have covered. How do we suspect and diagnose BK virus associated nephropathy that we have covered? I think this much we have covered. So let's start with question number 14. Is that okay? Whoever is there, let me see. Okay. Okay. All of you are, if I can just ask, all of you are preparing for the EDIC Part 1 examinations, or what it's like? When is your exam, if I may know? Hello? Anybody is there?
The 23rd of September.
Sure. Okay. So let's make it a kind of little interactive only, or little 23rd of September. So most of the things we have covered in the last session, the questions that comes in the European diploma examinations. In today's sessions, we'll try to cover some tropical kind of infections. Tropical infections are called tropical infection, and they are one of there are few of the neglected diseases that we forget and we read less about whenever we prepare for the European examinations. But this kind of questions can still be very well come, because nowadays the things have become much more global. All questions they come, they are not related, they are not pertinent to particular part of the world. It incorporates the global problem. So we'll try to cover few of the tropical infections in today's session. So with that thing, let's start. Question number 14 of today. A 52-year-old farmer is admitted with fever, confusion, hypotension. Examination reveals an eschar on the abdomen and mild hepatosplenomegaly. Lab finding shows thrombocytopenia, elevated transaminases, and mild ARDS. What is the most likely pathophysiological mechanism leading to this shock? So, given the current questions, first of all, you need to understand what disease or what disease we are talking about. And once we understand that what disease we are talking about, then they are asking the main pathophysiological mechanism for that particular disease. So, which disease we are talking about over here? Anybody? Dr. Sandeep has told scrub typhus. Yes, Dr. Sandeep, you are right. So, tropical diseases are very so if you know these kind of diseases, they're very easy type of questions, to be very frank. So what will be the answer over here, Dr. Sandeep? So option A, endotoxin mediated systemic vasodilatation. B, vasculitis with endothelial dysfunction and capillary leak. Direct cardiotoxicity of Orientia Tsugamoshi, immune complex mediated hypersensitivity, or adrenal insufficiency due to direct adrenal inhibition. So which one is the correct answer? Again, EDIC part 1, there will be some amount of theoretical component over here. Most of the questions in the EDIC part 1 examinations are also practical based, but you can expect few of the questions which require some theoretical knowledge as well. So this is kind of more theory based kind of questions. What will be the answers? Anybody has given answer? Let's check. Dr. Sandeep has told. Dr. Sandeep B. Anybody else? Anybody else wants to volunteer and participate? Again, in EDIC part 1, there is no negative marking. Everybody should understand that. So everybody, even if you do not know the answer, you should try and take at least one option in EDIC part 1, because there is no negative marking. So I would request everybody to volunteer and give their own response, because that tells us how we are thinking. Anybody else wants to volunteer? Or otherwise we'll be happy, we'll be content with Dr. Sandeep's response. So I think Dr. Sandeep is, oh, one more answer has come. Dr. Dattatray, he has suggested the option A. Okay. So let's see who wins, Dr. Dattatray or Dr. Sandeep. Okay. So I think Dr. Sandeep is the right, and he has given the right answer, because what disease we are talking about? The disease that we are talking about, especially the question is very, very straightforward, because it talks about the eschar inside the abdomen. Whenever we talk about the eschar, it is eschars are pathognomic of scrub typhus. And scrub typhus is one of the common tropical disease. And the main mechanism of the pathogenesis that leads to the multi-organ dysfunction in scrub typhus is a vasculitis, severe vasculitis kind of feature. That happens because of this infection. And that is why previously there are a lot of studies which suggested to use steroid in severe scrub typhus infection. So although in latest studies that the role of steroid has become a doubtful probably, so we do not use steroid nowadays to treat scrub typhus infection, but previously it was used because the mechanism of injury over here is vasculitis, and the vascular injury is causing capillary leaks. Okay. Any doubt? So again, this is the kind of you know or you do not know kind of question. So if you know, you will be giving right answer. If you do not know, most likely your answers will be wrong. So it's like that. Coming to the question number 15, again, this is a kind of either you know or you do not know. So, but I feel it is relatively an easy question. Which of the following is the most sensitive early diagnostic test for scrub typhus in ICU setting? Well-Felix agglutination test, IgG ELISA, IgM immunofluorescence assay, real-time PCR, and blood culture. Again, I would request you to give your input or give your answers to this question so that you can proceed. Anybody? Let's see, has anybody given some answer in the chat box? No answer so far. Should we wait for some more time? Dr. Sandeep, I think this is relatively straightforward question, and anybody who is working in the part of this India or where the scrub typhus is quite commonly seen, we do this kind of tests. And even though somebody who has not seen scrub typhus, they can also apply a common sense and give their answer. We got some response. Okay, let's see. Dr. Sandeep C, Dr. Gatra try A. Okay. Okay. So again, I think I have highlighted these questions in bold. What is the most important aspect of the question? The most sensitive and early diagnostic test. In the EDIC part 1, do not expect this kind of bold written part of the question. We need to find out which one is the most important aspect of the question. So here the most important part is the most sensitive and early. So while IgM, this is anybody answer? A guessing, okay. Dr. Lapani, okay. A. So again, well, Felix, IgG, IgM, they're all tests which are immunological tests, and the common sense test tells you that the immunological tests come positive after a week. So it usually they do not come positive the early phase of the disease. Blood culture, they are not the good test for diagnosing the scrub typhus because these bags that do not require culture to grow. So the answer to this question is the PCR based tests to detect DNA, Orencia Sutsugamoshi DNA. So PCR based tests are the most sensitive and they come positive the earliest over here. So the answer over here is the PCR based test as a diagnostic test. Okay. Any doubt? Or we'll go to the question number 16. Last time we spent a lot of time in procrastination. So this time we'll have to finish. A patient with suspected scrub typhus has negative IgM ELISA on day 3 of illness. So again, this question tells you that we have done some tests day 3 and we have found IgM ELISA is negative. What does it mean? That means that maybe IgM ELISA has been done pretty early within the window period where the IgM ELISA still has not come positive. So what is the most appropriate next step in confirming the diagnosis? What do you do? Should we repeat an IgM ELISA after 7 days? So they perform well Felix test immediately. So they initiate empiric steroid and monitor. So they start chloramphenicol and avoid diagnostics and discontinue suspicion and evaluate for malaria. What do you think? So, oh, sorry, I have not seen anybody has given answer. So Dr. Sandeep, yes, he has given the right answer. A is the right answer. So to confirm the diagnosis, we need to do another IgM ELISA after 7 days because they're not detectable in the first week of the disease. Testing with the PCR is recommended for the early detection, and for anybody who is having very high suspicion, we should repeat the IgM after 7 days. So that is the dictum. Treatment with steroid. Again, we start empirical antibiotics for any kind of highly suspected case of scrub typhus, like doxycycline. We give a kind of an empirical antibiotic of choice. We do not give empirical steroid. I've already told that steroids are no longer used in the treatment of the scrub typhus. And here the question is to confirm the diagnosis. What will you do? So to confirm the diagnosis, we need to do a repeat IgM ELISA after 7 days. Is that okay? So let's move to. So this is the diagnostic approach of the scrub typhus. Anybody who has a fever for more than 5 days and coming from endemic area exposure, you do a baseline labs, and then after more than 5-7 days, we send out IgM ELISA. If positive, then it confirms the diagnosis. If negative, but still is a high suspicion, we start empirical doxycycline and we monitor response. If the response is there, then we just continue it. Suppose the response is not there, other diagnoses are sought for, then we can always change our path. But otherwise, this is the kind of diagnostic path that we commonly follow in patients with the scrub typhus. Question number 16. So next few questions will be questions on malaria. Which of the following best describes the mechanism of cerebral malaria? So does it cause immune-mediated demyelination, endothelial invasion by merozoites, capillary sequestration of parasitized erythrocytes, direct toxin releases by cyzones, or CSF flow obstruction by parasite debris? I think again, people should be aware of the pathophysiology of cerebral malaria and the pathophysiology of any prominent diseases that we see in day-to-day basis. What should be the, anybody has given answer? Let me check the chat box. Okay, Dr. Dattatray has given answers to C. I hope this is the answer over here. So answer is quite synchronous over here, as I can see. Dr. Sandeep has given C. Dr. Saiful Kazi. Okay. Dr. Lakar. Okay. Doctor has given C. So everybody is given C. Is that okay? So I feel everybody is right over here. So again, this is kind of questions you know and you do not know. If you know, you will be able to give the right answer. So what happens? Cerebral malaria is caused by cytoadherence of the infected RBCs to the endothelium. What do you mean by cytoadherence? Like the RBCs gets clumped together and they get adhered to the endothelium and then block the capillary microvasculatures. So it causes capillary sequestration of the parasitized erythrocytes, right? So that is the rightest answer. We'll go to the question number 17. A patient with severe malaria is being treated with IV artesunate. On day 8, he develops hemoglobin drop with elevated LDH and reticulocytosis. What is the likely cause? So again, there's a question on the treatment part, which is very, very favorite things. So most of the questions in EDIC part 1 are based on the management of the patients. So this is a kind of on the basis of the management of the patient. So option A, it's an acute hemolysis due to high parasitemia, drug-induced immune hemolytic anemia, delayed hemolytic anemia due to artesunate, G6PD deficiency induced hemolysis, and autoimmune hemolytic anemia. What do you think? Let's guess, or somebody who knows can give the answer. Let's see the chat box over here. Yeah, Dr. Dilakana has told it is G6PD deficiency induced hemolysis. Any guess? Anybody else? Anybody else? Please provide your answer because this is important. So answer over here is, so Ati, Dr. Dattatray has raised hand. Okay. You can unmute Dr. Dattatray and ask.
And sorry, it was wrongly. Sorry.
Yes, sorry.
No, sorry. It was wrongly marked. Sorry.
No problem. No problem. So answer to this, please. I'll request you, I'll urge you to provide answer to all the questions because again, there is no negative markings over here and nobody is here to judge you over here and judge your knowledge. So I request you to be more communicative and then ask questions for anybody, whatever doubt do you have, anybody you have. So over here, again, what is the problem over here? The somebody who is already on artesunate is usually being given for 5 days. But day 8, he has developed drop in hemoglobin, it elevated LDH and the reticulocytosis. That means he is having some hemolysis. Hemolysis, delayed hemolytic anemia is one of the side effect of artesunate. Everybody should know. Again, they said either you know or you do not know. If you know this question answer, then you'll be able to provide answers. If you do not know, most likely you will provide answers wrongly. Now, why it is not because of this acute hemolysis? Because the patient is on a day 8. Somebody who develops acute hemolysis because of the malaria that happens within first day, second day, third day. So they do not happen after day 8. So it's not acute hemolysis due to malaria itself. Artesunate can cause, it's one of the side effects everybody should remember. One of the side effects of artesunate is to cause hemolytic anemia. So that is the right answer. Again, there is no question. Artesunate is not a drug which can cause hemolysis in a patient with a G6PD deficiency. So there is no relation between the G6PD deficiency and artesunate. So if somebody is having G6PD deficiency, we prefer not to give the drugs like primaquine. If the questions revolved around the primaquine, then probably G6PD deficiency would have been the right answer. But here the primaquine has not been mentioned, so the G6PD deficiency is not the right answer. So mostly it is the delayed hemolytic anemia due to artesunate. Patient might be having automatic hemolytic anemia sometimes can happen in malaria, but again, here the question is very, very clear about this artesunate. So the answer should be artesunate. Is that okay? Okay, so let's proceed. Which of the following is not an indication for ICU admission in malaria? Okay, so regarding the management of malaria, there is a standard WHO guideline. Anybody who is going for the EDIC Part 1 examinations, please read that guideline because that is a standard international guideline that are followed by the entire world. There are some society-specific guidelines, there are some national guidelines. Usually, it is better to follow the international guideline and the guideline whichever is provided by the organization like WHO. So please go and read through it and be prepared for the management of the malaria or any disease. Like WHO has a guideline on management of dengue, WHO has a guideline for management of malaria. All these guidelines will be able to everybody should go through and then able to give answers. So which one is the following is not an indication for an ICU admission? Hemoglobin less than 7, seizure, parasitemia more than 5%, acute renal failure, splenomegaly without rupture. So, okay, somebody has provided some answers. Let's see. I do not know. So, some answers are there. A, E. I think they are the answer for these questions. Yeah, I think so. Keep it here. So we got two different kinds of answers. Regarding the ICU admissions, again, suppose somebody is having the right answer over here is E because Anybody who is having hemoglobin less than 7 because of after the malaria, that means they are having hemolysis, that becomes an indication. Seizure, that means the patient is having cerebral malaria, is an indication. Parasitemia, more than 5%, they are at high risk of having a complication, so that is an indication. Acute renal failure is definitely an indication for an ICU admission. Splenomegaly without rupture. Sometimes the patients develop spontaneous splenomegaly after spontaneous splenic rupture after malaria. So that becomes an indication. But simple isolated splenomegaly is very common in malaria. So a lot of people with a chronic malaria, they develop a chronic splenomegaly. So most of the patients with the malaria develop splenomegaly. So they are not a direct indication for an ICU admission. So that is it. That is the answer. Question number 18. Question number 19. 32-year-old male returns to Risha with fever, chills, and dark red urine. On examination, blood pressure is 90 by 60. Pulse is 118. Sclerolictus is present. Labs is 7.8. Creatinine 2.9. Peripheral smear Plasmodium falciparum with 8% of parasitemia. Urine is showing hemoglobinuria, no RBC. What is the most likely cause of renal impairment? So, what is this patient suffering from? Anybody? Anybody can tell what this patient is suffering from? The question over here is what is the most likely cause of renal impairment? That is the question. So, for that thing, everybody should be able to understand what is this patient suffering from. The options over here are volume depletion with a prerenal AKI, hemoglobin-induced acute tubular necrosis, glomerulonephritis from immune complex, arterial toxicity, or acute interstitial nephritis. What do you think that is the cause? What is this patient suffering from? Anybody? Are these questions very difficult? I do not know. Nobody wants to volunteer. Severe malaria. Yes, this is severe malaria. I agree with doctor. This is severe malaria. So, but what is the major problem in what kind of severe malaria? Cerebral malaria is also very severe malaria. But definitely we are not talking about cerebral malaria over here. What are we talking about? What kind of severity we are talking about over here? So we are talking about severe intravascular hemolysis that sometimes happens in the malaria. So suppose somebody has developed severe intravascular hemolysis because they've given a clear-cut hint. This patient's hemoglobin level has gone down. His BP is less. His creatinine is raised. He has a very high parasitemia. His parasitic load is quite high. And urine is showing hemoglobinuria. So what is the cause of this kidney involvement? The answer is hemoglobin-induced acute renal tubular necrosis. So what does this cause? Hemolysis in falciparum malaria can lead to hemoglobinuria and direct tubular injury, which is a hallmark feature of, it's called black water fever. So what does it happen? Patient passes black urine. So that is why it is called black water fever. Why black urine? Because the urine becomes so dark and so dark because of this hemoglobin presence in the through the passing through the urine. So it's called black water fever. Okay. So complications of the malaria, everybody should read. Everybody should read about the complications of the malaria, severe malaria, cerebral malaria. These are the very, very favorite things about. And everybody, all intensivists should know about the complications of the malaria, because unless you know, you will not be able to treat them. Okay. So next go to the question number 20. Again, we are continuing with malaria. A 36-year-old man with severe Plasmodium falciparum malaria shows rising parasitemia, now almost 22% after 48 hours of IV artesunate. He is on mechanical ventilation, norepinephrine, and has acute kidney injury requiring CRRT. Okay. PCR shows some nutrition. Okay. So what is the most appropriate next therapeutic step? What do you think that is happening? The answer, oh, I have already given answer. The answer is that suppose somebody with a severe, very high parasitemia, more than 10%, so that requires an exchange transfusion. So, and this mutation tells you that the patient is having artemisinin resistance, so probably we'll have to give some other medicines like quinine and all. But at the same point of time, we need to start exchange transfusion because this is a kind of one thing that to bring down the parasitic load inside in the body. Okay. Any question? No. Okay. Should we proceed? We are still on malaria. Malaria is again very, very favorite topic. A 50-year-old female completed treatment with IV artesunate for falciparum malaria. On day 5, he developed severe hypoxia. Chest X-ray shows ground glass opacities and interstitial edema. CRP, ferritin are elevated. Cultures are negative. Question: what is the best explanation and management approach? Number 1, post-malaria cytokine storm. Initiate high dose of steroid. Artesunate pulmonary is post-malaria cytokine storm, so we should initiate a high dose of steroid. B, artesunate-induced pulmonary toxicity, we should discontinue the drug. Delayed ERDS due to parasite clearance, we should continue the lung productive ventilation. Secondary fungal pneumonia, start antifungal, or delayed TRALI, wasted transfusions. So, what do you think that is happening over here? Any volunteer? I expect at least one volunteer to answer. Anybody? Should I wait for you to give answer? To be very frank, I feel everybody of you are doing good. So all of you should pass. But again, please feel free to give answer. Anybody? Okay, Dr. Sandeep K has given answer C. Okay, very good, very good. Anybody else? A guessing. Okay, okay, okay. Okay. So answer over here is the C, as Dr. Sandeep has said. So as I'm telling you repeatedly, everybody should be aware of the complications of the malaria that can come. They are associated. So ARDS are very commonly associated with malaria. A lot of people, especially the falciparum malaria. Not only falciparum malaria, in India we see a lot of ARDS associated with benign malarias as well. Plasmodium vivax malaria associated ARDS also we see. So, and that happens because of this body's attempt to clear the parasite. So this is common in malaria. So falciparum malaria are very notorious to cause ARDS. So whenever we suspect ARDS, we suspect ARDS over here, and then we initiate the lung protective ventilation because the patient is having severe hypoxia and the PF ratio is less than 100. So we should start on lung protective ventilation for this. Steroids are not really recommended unless indicated for other reasons. For all these situations, previously steroids were commonly used, but nowadays they are not used. Just 1 minute. Phone is. Okay. So should we go to the next question? Or anybody has any doubt on malaria? No answers. Are you enjoying the class? Or you got bored? No answer. So let's try and read few of the basic facts of the malaria. There are two possible types of malaria, complicated and uncomplicated. Uncomplicated malaria means that when it is only fever and some headache, vomiting, and some influenza-like symptoms, they're the part of the uncomplicated part. Complicated part is that when there is a neurological involvement, pulmonary involvement, malaria, developing shock or kidney failure, they're all the part of the severe malaria. Especially the brain involvement, renal involvement, and lung involvement, they are termed as severe malaria. So in severe malaria, mortality are quite high. How do we diagnose malaria? Two things, light microscopy and the rapid diagnostic tests. They are the facts, again, everybody should know, and the questions come on these facts multiple times and has come in the past multiple times, so you should know. Light microscopy, they're highly sensitive, specific. The advantage is that they are quite sensitive and specific. The cost is less. We can differentiate between the Plasmodium species. We can determine the parasite densities, like what is the parasitic index that we can calculate by the microscopical tests. We can monitor the response to the treatment, like there's somebody with having a high parasitic density has come down now with the treatment, that tells you the treatment are being effective. The disadvantage is that the diagnosis depends on the microbiologist or microscopist who is actually looking through the microscope, and the limit of sensitivity is approximately 100 parasites per microliter. But the rapid diagnostic tests, which are quite popular tests to diagnose malaria, they provide rapid result, card-based tests. They require less training, less skilled personnel. But what is the problem? We usually will not be able to distinguish between the new infection and the previously affected infection, because once somebody's rapid malaria antigen test comes positive, it persists for almost month even after effective treatment. So the positive malarial antigen test doesn't mean that it's a recent infection or it is some past treated infection. It cannot detect the infections from by Plasmodium malariae and the Plasmodium ovale. So it only can detect the infections with the Plasmodium vivax and the Plasmodium falciparum. And the sensitivity, they are quite sensitive, but again, still now the gold standard for the diagnosis is the light microscopy. WHO guideline that we are talking about, we should know about the WHO guideline for the malaria. Has been published. It has been last edited in 2023. For uncomplicated malaria, for Plasmodium vivax, chloroquine followed by primacin is recommended. For Plasmodium falciparum, we give the artemisinin-based combination therapies over here. And for the mixed, we give artemisinin-based combination therapies. For severe malaria, the parenteral artemisinin is the choice if it is available. And if it is not available, then quinine-based therapies are the choice. Quinine along with the doxycycline or clindamycin. Now we go to the question number 22. Which of the following infectious agent is most classically associated with severe rhabdomyolysis and EKI? Okay, the questions are again. So they are asking about what is the infectious cause of rhabdomyolysis. They have given 5 options: Legionella, Staphylococcus infection, Plasmodium vivax infection, Candida, Epstein-Barr virus. Anybody? Any answers? No. 1, 2. Okay. I think Dr. Lakane has given A. Dr. Sandeep has given B. Dr. Dattatreya has given A. Okay. Any more answers? Anybody wants to guess or anybody wants to give answers? Again, it's one of the tricky question. Again, and you know or you do not know kind of question. The answer over here is A. Legionella pneumophila. Legionella is notorious to cause rhabdomyolysis. Legionella, they are sometimes we see Legionella infections in our hospital as well. So there are quite a bit of complications that are associated, or quite a bit of unique features of Legionella infections, because they sometimes present with atypical kind of presentations, like some loose motion or something like that. They are quite commonly associated with hyponatremia, Legionella infections, and rhabdomyolysis is one of the very specific complications for Legionella. For Plasmodium falciparum, they are associated with rhabdomyolysis. Plasmodium vivax is not very commonly associated, commonly known to be associated with rhabdomyolysis. Okay. What are the common infections that can precipitate rhabdomyolysis? Bacterial infection, Legionella, Leptospira, any necrotizing fasciitis, toxin-mediated myositis from Streptococcus or Staphylococcus, viral infections like influenza A, B, dengue virus, Coxsackie virus, and parasitic infections like Plasmodium falciparum. So they are the common infections that can precipitate rhabdomyolysis. Okay. Clinical clues suggestive of infectious rhabdomyolysis. Somebody comes with a fever, myalgia with a dark urine, with an acute kidney injury with a very high CPK level, creatine phosphokinase level, and with a recent history of travel or viral infections or exposure to the contaminated water or rodents or hypertension, sepsis, pneumonia. If somebody comes with pneumonia, we should think about Legionella. Flu-like symptoms, we should think about influenza or dengue. So they are the clinical clues suggestive of infectious rhabdomyolysis. Okay. Proceed. Question number 23. A 40-year-old man with a dengue infection. So next few questions will be on dengue. 40-year-old man with dengue infection develops hypotension, myalgia, and colocarditis. Okay, his CPK level is 18,000. Okay, so I hope everybody is able to understand what we are talking about. The creatinine rises 3.6 milligram per dl. He has no pulmonary edema, and his urine output is 0.3 ml per kg per hour. Question is, what is the most appropriate fluid strategy? A. Restrict fluid, initial vasopressors. B. Begin aggressive isotonic saline hydration. C. Administer mannitol. D. Renal replacement therapy. E. Avoid fluid. I request again everybody to provide answers. So somebody has given answers. Let's see. Dr. Abhishek Jha has given answers B. Okay. Anybody wants to give answers? Anybody wants to guess? So what are we talking about over here? So somebody has developed rhabdomyolysis from dengue. So what we should do? So anybody? No. So it's a basic questions of the rhabdomyolysis. So and it's very common questions. Anybody, it can come with any other cause of rhabdomyolysis as well. Somebody who has developed rhabdomyolysis, what we should do? Yes, now we are getting answers. Good, very good. So we need to give some clues. So I think Dr. Abhishek, Dr. Sandeep, Dr. Saifun, everybody, all of you are, I think you're right. So anybody who has developed rhabdomyolysis, the first and foremost thing is to start isotonic saline hydration. So that is the basic management of rhabdomyolysis. So we need to hydrate the patients. Early aggressive hydration is vital for rhabdomyolysis to prevent cast formation and protect kidney function. Unless somebody is fluid overloaded, we should not do that. But most importantly, we should start hydration for all patients who has developed rhabdomyolysis. Good. Yes, aggressive fluids initially. Dr. Abhishek is right. Very good. I'm very happy. You're all giving right answers. Going to the question number 24. Which of the following best explains the mechanism behind the shock and organ dysfunction in severe dengue? Direct viral cytopathic effect on the end organs, immune complex mediated deposition in the small vessels, antibody dependent enhancement causing cytokine storm and the capillary leak, intravascular hemolysis and hemoglobinuria, and microvascular thrombosis due to platelet activation. What do you think? So we have done few questions on the pathophysiology of the disease. I have kept all those things intentionally because a lot of time we skip the pathophysiological aspect of the disease. So if you read for anybody who is appearing for the EDIC exam, they should all read the ESICA module. I hope everybody is aware of the ESICA module. And if you see the ESICA module, one of the core part of this module is to discuss about the pathophysiological aspect of the disease. So it is not ignored. So the question can come from on the pathophysiological part. Okay, let's see who has given answers to it. So Dr. Abhishek has again good. He has given the answer C. Dr. Dattatray has given answer C. Anybody else wants to try? Either they know or they can try the luck. Again, EDIC part 1, I am repeatedly telling EDIC part 1, there is no negative marking. So everybody should give answers to all questions. And especially in this kind of platform where nobody is able is there to judge you. So you can give your answers and see that what is happening, whether you're right or wrong. Even you should judge, you should see to whether your guessworks are right or wrong. So try your luck or give your answers, see that whether it is being it's matching, or suppose if you do not agree to the answers that has been provided over here, you can just feel free to tell me. Okay, the answers over here has come as C, C, E, C. Okay, good. At least we are getting some answers over here. So the answer over here is the C. Good. So the dengue is one. Again, who has given some answers? Let's see what's given. Yes, capillary leak. Good. So capillary leak is very commonly associated with dengue. Right. So anybody who knows that who have seen dengue patients, they should know that suppose somebody has come with a severe dengue, they develop severe capillary leak, and that happens because of the cytokine storm. All patients with a severe dengue or severe dengue HLH, they develop cytokine storm and they can come with a capillary leak. That is why in the recovery phase of the dengue, we see the patients come with a fluid overload, either with a fluid inside the chest or fluid inside the abdomen, and they come with a lot of third spacing. Because that cause, whenever the body tries to develop immunity against the dengue, it can lead to a cytokine storm. Okay, so plasma leakage and the increased vascular permeability, they are the common pathophysiological mechanism for severe dengue infection. Good. Going to the question number 25, a 42-year-old man with dengue is admitted with ICU, admitted to the ICU with altered mental status. His AST is 1200, ALT is 1100, INR is 3.1, ammonia is 92, platelet is 28,000, no active bleeding, CT brain is normal. So what is the next best step in the management? So again, to understand what is the next best step in the management, we should know what the diagnosis we are talking about over here. So somebody who has come with a dengue, severe dengue with an altered mental status and transaminitis, raised ammonia, low platelet count, what are we talking about? Anybody? Which entity we are talking about? We're talking about dengue, any complications of dengue, any superimposed pathophysiology of the dengue. What are we talking about? Anybody wants to volunteer? Dr. Abhishek, Dr. Sandeep, Dr. Lakane, Dr. Dattatray. So these 4 people, they are regularly giving answers, which is good. I encourage all of you to provide answers. Okay, Dr. Abhishek, you told about dengue encephalitis. Okay, anybody else? So, yeah, dengue encephalitis might be possible, but what is the reason for this raised liver enzymes or raised INR? So what were you talking about? No, liver failure. Good, good, very good. Liver failure, acute liver failure. Very good, very good. Dengue can cause liver failure. Everybody should know. Dengue can. So the question is HLH. Very interesting, Dr. Dattatray. Very good. So I hope everybody has seen a severe dengue, and I pray that nobody sees severe dengue because they are associated with very high mortality. So what is the next best step in the management? Anybody wants to volunteer for the answer? Start N-acetyl cysteine infusion, initiate mannitol for cerebral edema, intubate and start lactulose, begin steroid, broad spectrum antibiotics, and transfuse platelet urgently. What do you need to do? Anybody wants to provide answer? Or Suppose somebody is feeling that it is ALF, what do we need to do? Somebody who is thinking it is dengue encephalitis, what do we need to do? Oh, answers are coming. It's B, B, A. Okay, good, good. Mannitol. Okay, mannitol. Now we can give mannitol, but okay. Dr. Sandeep has told start in acetylcysteine. Okay, I hope you are doing that in acetylcysteine infusion for anybody with ALF. C again is a good answer. It's not a bad answer at all. Intubate and start lacrimose. Okay, yeah, it's a good thought process. But okay, anything lacrimose won't help in ALF. Okay, so that is one thought process. Good, good. Let's try and understand what is the thought process. So then I can tell you the answers and probably I can modulate your thought process. Let's see what happens. Anybody comes up with the right answer? Somebody has talked about dengue HLH, but he's not giving answers to it. What is the treatment of dengue HLH? Okay. So answer over here is the acetylcysteine infusion. Why again? Because anybody who is suspecting an acetylcysteine infusion, then probably you can start an acetylcysteine infusion. Yes, you can do it. That is the answers that has been given over here. But to be very frank, anybody who has thought of intubating somebody with an alternate stress and ALF is not a bad thought process at all. Mannitol for cerebral edema, so that means that you know that the acute liver failure is associated with cerebral edema. So they have been tried. So people tries mannitol with in acute liver failure. Although the better choice probably will be a 3% saline and then other brain protective measures, but mannitol are not uncommonly used in cerebral edema as well. So that is good. But here the answer is in acetylcysteine. There will be some questions will be in this kind of confusing things, but okay, it's okay. Let's move forward. A 33-year-old man with day 6 of dengue develops worsening hypoxia, hypotension, elevated creatinine, and rising liver enzymes. Chest X-ray shows bilateral infiltrations, is oliguric and respiratory distress, platelet is 25,000. What is the most appropriate mode of renal replacement therapy over here? Okay. Now let's see the whole. So it talks about the renal replacement therapy in patients with a dengue. With the raised liver enzymes and the raised creatinine. Anybody? No answer? I don't know, whoever. Anybody else wants to give answer? Provide answer. 1, 2, 3, 4, 5. CVHDF. C. Okay. E. Conservative fluid management. Okay. B. Okay. So the answers over here is, as most of you have told right here, is a CVHDF because this patient has developed hypotension with elevated liver enzymes. So probably we are talking about and excessive bilateral infiltrates. Probably he has the features of fluid overload as well because of this raised creatinine or because of this liver failure component. So CVHDF is the preferred choice in somebody who is hypotensive or hemodynamically unstable and with multi-organ dysfunction. So most of the time we'll end up doing a CVHDF or TRRT. IST and the SLATE, they are less preferred mode. Somebody which the center which do not have the facility of CVHDF, SLATE are tried, but the choice is to do a continuous renal replacement therapy in the form of CVHDF. 40-year-old man with a no travel history at present with low-grade fever and mild thrombocytopenia and a mild ALT elevation. There is no rash or bleeding. He is hypotensive but alert. His dengue initium and the IgM is negative. CRP is 6. What is the next best diagnostic step to evaluate the dengue in this patient? Order dengue IgG. Okay. So here you want to diagnose dengue in this patient. So what will be the best step to evaluate this the dengue in this patient? Send dengue PCR, perform bone marrow biopsy, test for chikungunya, leptospira, repeat NS1 or IgM after 48 hours. Okay. Okay. So let's see who gives the right answer. Okay, good. We have already started getting the response. The doctors who are there, they are providing the answers. So good. Okay, Dr. Dattatai talked about B. Dr. Sandeep has talked about E. Dr. Abhishek dengue PCR. Dr. Saifokaji talks about B. Dr. Dattatai talks about Dattatai, I think. Okay, so there is the last answer. So we got 3 responses in favor of B and 2 responses in favor of E. Okay, so if again the diagnostic step over here is the PCR because the patient is having we're suspecting dengue over here as we have told over here. The PCR based tests are confirmatory, especially in the early phase of infection. So we should say that it's a dengue PCR is the answers. We can send another IgM, especially IgM. NS1 usually doesn't. NS1 is very specific for the dengue. That is true, but NS1 usually after 5-6 days the NS1 doesn't stay positive anymore. So after 5-6 days the IgM comes into the play. But in the early phase of the disease, the PCR based tests are the diagnostic. So again. It's just to emphasize that we should not think about PCR based tests in the dengue. 28-year-old male, dengue endemic region, presents with 6 days of fever, diffuse body pain, conjunctival suffusion, low platelet 42,000, urea 68, creatinine 2.1, AST 250, NS1 and IgM are negative, no rash noted, leptospira IgM is pending. Which finding is most helpful in distinguishing dengue and the leptospirosis? Okay, thrombocytopenia, elevated AST, hemoconcentration, renal department, and conjunctival suffusion. So that is how do you differentiate between dengue and leptospirosis before the confirmatory lab tests come? There's a kind of more clinical features of some disease. Let's see which answers can come. Either E or C, likely okay. There has to be only one answer. Okay. C. So the choice between the hemoconcentration and the conjunctival suffusion. Okay, that is understandable. So that tells me that okay, you see patients clinically, so that is good. So I would encourage all of you to continue to do that. So that because that's a good practice. Sometimes the examinations for clearing examination you should know what is the answer that is wanted in that particular clinical scenario. Answers over here is hemoconcentration. Hemoconcentration is a typical finding for the dengue's critical phase. Conjunctival suffusion that can happen that more common in the leptospirosis, and the renal failure are more common in the leptospirosis. But if you feel that it is more dengue going in favor of dengue, then if somebody is having a hemoconcentration that goes more in favor of dengue. So that is why the question is like that. Okay. We hope you have got the essence of the question. 29. We're almost on the fag end of the weeks, probably. 19-year-old female presented on day 5 with a dengue fever with new onset persistent vomiting, abdominal pain, rising hematocrit. The platelet count dropped from 95,000 to 45,000 in 24 hours. Ifeprine, but appears lethargic. NS1 antigen is positive earlier. So what is the most accurate diagnostic label at this moment? Okay, so which stage? So that it tells us that the question is about which stage, which kind of what stage the patient is in dengue. So patient has dengue, but now the patient is having new onset vomiting with pain abdomen, with rising hematocrit, and the drop in platelet. So dengue has three phases of dengue. If somebody remembers, again for dengue, everybody should know the WHO clinical practice guideline for the diagnosis and management of the dengue, because that document is extremely well crafted and written. Dengue fever, is it a recovery phase? Let's see who has given the answers. Dengue, warning sign, very good, Dr. Abhishek. Very nice. Anybody wants to give any more answer, or everybody feels that Dr. Abhishek is right? Dr. Sandeep feels otherwise. He feels that he's in dengue hemorrhagic fever grade 1. Okay. Anybody? Anyone? So let's see whether to go with Dr. Abhishek or Dr. Sandeep, because nobody else has given answer too. It's not, patient is not in shock. So it's not, it's understandable patient is not in severe with shock. They are not in recovery phase, they are not recovered dengue. So that is true. So I feel that the dengue warning signs B and D is the possibility, very well possibility. What is the answer over here? I feel it is the answer is D, because yes, because this is somebody who has a new onset persistent vomiting. They are the sign of dengue warning sign. I'll talk about this dengue warning sign in a little bit of details probably in subsequent slides. So transition from febrile to the critical phase is marked by the fever goes out, the warning signs comes. Warning signs means vomiting, pain abdomen, and rising hematocrit. They are the warning signs, and the plasma leakage starts. Dengue hemorrhagic fever, why it is not the answer? Probably because there is no evidence of bleeding in anywhere over here. So probably that is why patient probably is going in a dengue shock syndrome. So dengue hemorrhagic fever, when we diagnose whenever there is a drop in hemoglobin. So whenever there is a rising hematocrit, we do not diagnose dengue hemorrhagic fever. Hemorrhagic fever means somebody is developing bleeding. So there will be a drop in hemoglobin. So here the patient is going in a dengue shock. And before dengue, patient has actually gone into dengue shock, he is in a kind of dengue with a warning sign. So we need to be all be very, very alert. So we'll talk a little bit about the dengue. Dengue can be asymptomatic or symptomatic. Symptomatic dengue can be labeled as undifferentiated fever, dengue fever without hemorrhage, with hemorrhage. Dengue hemorrhagic fever can be dengue hemorrhagic fever with shock or without shock. And there is some expanded dengue syndrome. These are the WHO guideline based to the three phases of dengue. Dengue, simple dengue without any complications, then dengue with or without warning signs, and severe dengue. What are the warning signs? Somebody who has documented to have dengue, and now his fever has gone down, and we feel that he is recovering, but now is a new onset abdominal pain, vomiting, or the clinical evidence of the fluid accumulation inside the chest or abdomen. Somebody is having bleeding, somebody who is lethargic or restlessness, or some kind of altered sensorium, liver involvement, increasing hematocrit. They're all the warning signs. There are seven warning signs we always need to know. The pain abdomen, vomiting, bleeding, nuance bleeding, the serositis kind of picture, the altered sensorium, hepatomegaly, and the rising hematocrit. They are the features of the warning sign, dengue warning sign. Dengue, why we need to know all these signs? Because anybody who is a dengue warning sign, we need to be careful, and that they can we very well lead to form of severe dengue. Severe dengue means either dengue shock syndrome, and somebody can be with a dengue hemorrhagic fever, or somebody can be with patients dengue with a capillary leakage, or patient with a respiratory distress, and severe organ involvement, CNS involvement, heart or other myocarditis or other organ involvement. They are all termed as severe dengue. So warning signs that we have talked about. Expanded dengue syndrome, again you should know because the questions sometimes come. What are the expanded dengue syndrome? Dengue with neurological symptoms, GI manifestations, renal involvement, cardiac involvement, respiratory manifestations, and the hematologic involvement. They termed as a expanded dengue syndrome. We should know what are the organs that can get affected with the dengue. And one important thing you should know that the dengue, what is dengue? HLH or macrophage activation syndrome that happens due to activation of the T cell activation. And how to diagnose HLH? We should know there is an entity called H score. There is an H score calculator is there in online. Anybody with a severe dengue, we should calculate the H score and then get the probability of having a severe probability of having a dengue HLH in that patient, depending on the few criteria. These are the criteria. And based on this criteria with the H score, they give us a probability of having a hemophagocytic syndrome. Certain amount of the dengue, I feel everybody should know whoever is practicing in the intensive care unit. The choice of fluid in dengue is isotonic balanced crystalloid, lactate, or plasmolite, or something like that, balanced salt solution. The duration should not exceed more than 24 to 48 hours, because after 48 hours, the patient develops capillary leak and it expands it aggravates the capillary leakage. Always we should check the signs for the fluid overload, because somebody in the recovery phase of the dengue always sometimes go in the fluid overload because the sequestration of the fluid coming back into the circulation. And we should check hematocrit to guide fluid resuscitation in absence of bleeding. So suppose somebody has come with a severe dengue with hemoconcentrations, you give fluid, the patient is not bleeding and the hematocrit level is coming down. That means probably you are giving the right amount of the fluid. Indication of the platelet transfusion, again, I should always emphasize transfuse platelet only if the bleeding is present, or prophylactic transfusion only if the platelet count is less than 10,000. There's a standard guideline. We should not start transfusing the platelet more than when the platelet count is more than 10,000. So there is a kind of treatment management algorithm given by the WHO for the management of the dengue. I'm not going through that. You can go to the WHO site and then download that. Download this slide from. And management of the dengue HLH. This is one important thing I feel that everybody should know. We should suspect dengue HLH in all cases with severe dengue, especially when there is a persistent or recurrent fever more than 7 days, or somebody with having anemia without intravascular hemolysis or massive bleeding. So whenever we suspect, we check for the triglyceride, fibrinogen, and the ferritin, and we can check the NK cell activity and all if we have the facility. The treatment is adequate hydration, correction of the anemia, thrombocytopenia, and organ dysfunction. Careful support for the particular organ which has been affected, and we should give steroid. Steroid is the choice. Yeah, okay. So usually the dexamethasone is a choice because most of the time they are associated with neurological involvement. So dexamethasone has a better penetration than methylprednisolone inside the brain. So we prefer to give dexamethasone for a few days in dengue HLH. I think with that thing, we end it over here. Any questions, all my dear colleagues? I hope today I will make time.
Good evening.
Yeah, good evening.
So I am writing my exam from South Africa. I
Yeah,
realized during these tutorials, there's a couple of diseases that I actually don't even know anything about, like the scrub typhus, and the BK viremia. Is there
okay.
anywhere where I can go and read up on these? Where can I get the information on them?
So again, as I'm emphasizing the fact, this the questions are the tropical diseases. So they are called the tropical diseases. They're not predominant in India. So there are few Western countries which do not see the tropical infections. But why they have started emphasizing on these tropical infections over here? Because now the this EDIC examination has become more global. It has not been limited to 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 the European countries only. And the tropical diseases have become a kind of very prominent infections in the majority part of the world, especially the tropical part of the world, and that is why we should know about those tropical infections. So last time we talked more about more sepsis and all the other parts of these infections which comes more frequently in EDIC. But it's not that the tropical infection questions on the tropical infection do not come in EDIC part one and part two. Even you can expect somebody sometimes. Suppose you are giving EDIC part two examinations in centers like India, any centers from India, you can very well expect a complicated malaria case as your long case. So those kinds of things are there. So, and for part one, that is more theoretical. So probably you should expect questions on the tropical diseases as well. I hope I could give answers to your question, Doctor. Yeah. Okay. Dr. Abhishek has asked.
Thank you.
Yeah. Thank you. No problem. Dengue with organ failure. Do you prefer steroid toxicity only? So again, the choice is to the modality. Usually, in the examinations, in any examinations, for whatever you give, like you give EDIC examinations or you give other examinations, like suppose if you're from India, you're giving DRMB, or if you're enrolled in ITCCL, they will not ask about the advanced modes like auxiliaries or something like that. So the questions will be basically on what modality of renal replacement therapy you will choose. So it will be a comparison between the CVV HDF and the SLATE, CRT versus SLATE, or CRT versus IHD, or CRT versus peritoneal dialysis, something like that. The questions will not be coming probably whether which filter will you use, auxiliaries or cytosorb or all those things. It's like that. If there is no more questions, then I'll stop sharing over here. Thank you for all for joining over here. Whoever is from India, today is a holiday in India. So thanks for joining on the holiday. I hope the class comes to your help to some extent, and I pray all of you do good in your exam. All the best.
Thank you, sir. Thank you, all the aspirants, for being here.